Hi, welcome to another DiepCFoundation YouTube video where we talk about all topics related to breast reconstruction. I'm back again with Dr. Tim Matatov with the Aesthetic and Restorative Breast Center in Phoenix. So we're very glad to have you.
Glad to be here.
I have a follow-up question. We did a video about stacked flaps. But while we were talking about it, I was wondering to myself, when a patient comes in prepared, thinking they're going to have a DIEP flap, and you have to educate them and inform them in a shared decision-making conversation, because our conversation obviously led me to believe that you do that with them. Tell me how that all happens, and what are some of the other things that are surrounding that decision about, coming into the decision about a stacked flap.
Sure. Well, the first thing is to obviously assess what the current breast size of the patient is, as well as what are the desired goals. Do you want to be small? Do you want to be larger? Stay the same. So if the patient would like to be, let's say, a C cup, but looking at abdominal tissue, I know I can only deliver a B cup at most. Obviously, in that situation, I would offer a stack flap, because it's an estimate, but knowing from experience, look at someone's abdomen, that I cannot deliver a C cup breast, I like to have, for the patient to have enough information to make a good decision. So at that point, I start talking about a stack flap, just because a single flap is not going to be enough. The other thing I consider is post-mastectomy radiation. So if the patient will be undergoing a post-mastectomy radiation, even let's say they undergo a mastectomy, then I place a tissue expander just as a placeholder in preparation for a flap. I do think that as the expander being removed and it's no longer pushing hard against the skin, and you put the flap in, the flap doesn't give you as much of a resistance to skin contraction as the expander does. So therefore, that breast tends to look smaller, even though the volume could be the same of the flap, but it will look smaller. So in those situations, maybe a stack flap would be ideal. Also, you kind of build on that breast reconstruction with a single flap, and then eventually do some serial fat grafting. But it's very challenging for patient to make those decisions, knowing that, okay, I have another 3 surgeries just to get to the size that I want. And it's also obviously managing patient expectation and being upfront, like, look, this is as big as I can get of a breast I can get for you. So if the patients are okay with that, then we can proceed with a single flap. But a lot of patients do choose to go with a stack flap, obviously knowing the risk that's a second area of donor site that has to be involved in this operation.
But you guys, I know at your hospital facility, you use the ERAS protocol, which is enhanced recovery after surgery.
Correct.
So if you do a stack flap, even with ERAS, does it extend the hospital stay because you have another donor site?
So majority of the stack flaps that we do are abdominal based. So if it's an extended abdominal flap, or we take both of the DIP blood vessels and bring it as a single unit, then it does not. But on some occasions where we do what's called a 4-flapper reconstruction, where we'll take both of the DIPs and both of the PAP flaps, those tend to be a little bit more invasive, so the patients stay about 48, sometimes a little bit longer. Most of our patients, if it's a regular abdominally based flap, stay somewhere between 24 to 36 hours.
So just to go over again, because we mentioned it in the previous video, so the DIAP, of course, is a deep inferior epigastric perforator, which is the stomach, but then you mentioned the PAP just a minute ago. That is the profunda
artery perforator flap, correct.
Which is in the thigh area.
Correct. It's
inner
thigh, and it's a little bit more posterior, which is kind of the back of the thigh, compared to a tuck flap, which usually tries to be at the center of the medial thigh or the inner leg. Just
a question out of curiosity. How many women, when they come into a consult like this, how many actually have ever heard of a stacked flap? Is it new to a lot of them? I've
only had one person that seeked me out from California for a stack flap. Usually people have no idea.
Wow.
Yeah.
I thought that was going to be the answer. Thank you so much, Dr. Matatov.
Yes, thank you.
Appreciate your time.
Yep.